The following lecture is aimed for senior dental students, interns, dental trainees, oral surgery and oral maxillofacial surgery residents, as well as master and doctorate degree candidates. In memory of my late parents, may Almighty merciful God rest their souls in heaven and peace. So first of all, please allow me to give a brief bio about the speaker. My name is Muhammad Ahmed Al-Shulqami. I'm currently a professor and the chairman of the Oral and Maxillofacial Surgery Department at the Faculty of Dentistry, Suez Canal University in Ismailia, Egypt. Actually, Ismailia is one of the most beautiful cities in Egypt. It is located around 80 miles to the eastern of Cairo, overlooking the Timsah or Crocodile Lake and Suez Canal. Ismailia was founded by and named after one of the great rulers of Egypt in the 19th century. He was Ismail Pasha or Khedive Ismail. He was the one who did the opening ceremonies of the Suez Canal in 1869. Beautiful scenery is always seen in Ismailia. You have a greenery landscape overlooking lovely blue sea, and I think it's worth visiting. And that's the place where I work. This is the Faculty of Dentistry complex. It is comprised of 3 main buildings. I'm also the professor and the supervisor of the Oral and Maxillofacial Surgery Department at Faculty of Dentistry, Sinai University, Kantara campus in Ismailia. I also worked as a part-time associate professor at MIU University and MSA University for several years. I'm a visiting professor at the Faculty of Dentistry, Beirut Arab University, in the Oral and Maxillofacial Surgery Department in Beirut, Lebanon. I'm also the managing director of the Egyptian Dental Center, a multi-speciality discipline dental and maxillofacial center based in Cairo, Egypt. This lecture is management of maxillofacial infection, talking about the pharyngeal and neck fascial spaces. What are the main topics of this lecture? Knowledge of the classification of neck fascial spaces, knowledge of anatomic boundaries, understand different routes of infection for each space, understand the clinical significance, and last but not the least, clinical picture and management for each. So let's get an overview about the classification of the pharyngeal and neck spaces. According to anatomic location, they are divided to suprahyoid and infrahyoid. The suprahyoid neck group includes parotid space, masticator space, with both compartments, the suprazygomatic and the infrazygomatic. The suprazygomatic of the masticator space includes the superficial and temporal spaces, while the infrazygomatic includes the pterygomandibular and masseteric spaces. And then we have the parapharyngeal or the lateral pharyngeal space, the prestyloid part. Then coming to the suprahyoid and infrahyoid neck group, we have the carotid space or the poststyloid parapharyngeal or lateral pharyngeal space, which is located in the suprahyoid neck, and in the infrahyoid neck it is termed the carotid sheath. The visceral space, which is infrahyoid in some definitions, including or contiguous with the pharyngeal mucosal space located in the suprahyoid region. And then we have the retropharyngeal space, which is including or contiguous with the dangerous space posterior to it. And last but not the least, the perivertebral space, which includes the prevertebral space anterior to the cervical vertebrae. On the other hand, we can classify the spaces into primary or secondary, as previously mentioned in other videos, where we have the primary, where the infection comes directly from the offending tooth. So in this case, the retropharyngeal, the dangerous space, and the lateral pharyngeal most probably are considered as secondary spaces. They receive the infection from other spaces which receive the infection from the offending tooth at the first place. However, this is not usually the case, because the lateral pharyngeal space can receive infection directly from third molars, particularly the mesioangular or horizontally impacted third molars, particularly with the roots directed towards the lingual plate of bone, where the infection can spread to the lateral pharyngeal space or the pterygomandibular space directly. So here it becomes or plays the role of the primary space. And here is a cross-sectional diagram of the suprahyoid neck. We can see on the left-hand side the arrows pointing to the prestyloid parapharyngeal or lateral pharyngeal space on either sides of the pharynx, and behind the pharynx or posterior to the pharynx, the retropharyngeal space, and more posterior or behind the retropharyngeal space, the danger space, or it is also referred to as the alar space. Then backwards we have the perivertebral space or the prevertebral, and last but not the least the carotid space, which is the post-styloid part of the parapharyngeal or lateral pharyngeal space. And on the right hand side we can locate the masticator space and the parotid space. Here is another diagrammatic representation in a sagittal section or sagittal view. We can spot the retropharyngeal space and the danger space posterior to it. And here is another view, a cross section on the left hand side, showing the retropharyngeal space behind the pharynx and the parapharyngeal space with the prestyloid and the post-styloid compartments. On the right hand side we can see there is a sagittal section also through the suprahyoid group. You can locate the pharyngeal wall, the tonsil, and the hyoid bone downwards, internal carotid artery, internal jugular vein, and the parapharyngeal space and parotid gland. And here is an axial CT showing the different anatomical locations and distributions of various spaces. We can locate the masticator space formed by the masseter muscle and the medial pterygoid muscle on either side of the mandibular ramus, and posteriorly there is the parotid space and the parotid gland, the parapharyngeal space in between, and the carotid space backwards in the post-styloid area of the parapharyngeal space. And we can locate the peritonsillar space and the retropharyngeal space. This is a nice color coding of the CT in order, if you can order a CT to find pus or fluid collection in one of those spaces, you can easily locate it by this color coded view. So let's go to the lateral pharyngeal space. What are the anatomical boundaries? On the right hand side we can see a transverse section cut in an oblique angle or an oblique fashion through the neck. We can have anteriorly the superior and middle constrictor muscles of the pharynx, and it is bounded posteriorly by the carotid sheath and scalene fascia. Medially it is bounded by the pharyngeal constrictor and the retropharyngeal space, while laterally it is bounded by the medial pterygoid muscle. Furthermore, superiorly it is bounded by the skull base, and inferiorly it goes as far as the hyoid bone. And we can see this in the sagittal section on the right hand side. What about the potential or possible sources of infection? Usually the lower third molars, particularly if they are mesioangularly or horizontally impacted or partially impacted, and the roots are a little bit deflected to the lingual side or towards the lingual plate of bone. Lower third molars might be a source of primary infection, and this might be the primary space involved from the lower third molar. However, infection can also get to this space from other areas like the tonsils, or infection coming from other neighbor spaces. What about the communications of the lateral pharyngeal space or the parapharyngeal space? We can see from the right hand side diagram, the cross section and the sagittal section. We can locate, it can communicate with several neighboring spaces like the pterygomandibular, the submandibular and sublingual, peritonsillar and retropharyngeal behind the pharyngeal wall. The lateral pharyngeal space contains the carotid artery, the internal jugular vein, the vagus nerve, and the cervical sympathetic chain. And the clinical representation is a swelling on the medial aspect of the mandible, extending or displacing the uvula and the lateral pharyngeal wall medially. And we can perform intra or extraoral incisions The intraoral incision is placed on the anterior border of the ramus, and we can introduce the hemostat medially to evacuate the lateral pharyngeal space. On the other hand, in cases of trismus, or if this intraoral incision is inaccessible, we can resort to the extraoral incision shown in the right hand figure. And coming to the retropharyngeal space, which lies behind or posterior to the posterior pharyngeal wall, and it lies medial to the parapharyngeal or the lateral pharyngeal space, and it communicates with it. So it is bounded by superior and middle constrictor muscles anteriorly, and it is bounded posteriorly by the alar fascia. It extends superiorly to the skull base, and inferiorly it is bounded by the fusion of the alar and the buccopharyngeal fascia at the level between C6 and T4 vertebrae, while on the lateral aspect it is bounded by the carotid sheath and the lateral pharyngeal space where it communicates with it. And here we can spot the buccopharyngeal fascia and the alar fascia, where they fuse inferiorly between C6 and T4 vertebrae, and the space extends upwards and superiorly as far as the skull base. And this is a sagittal section showing the relation of the retropharyngeal space and the danger space which lies posterior to the retropharyngeal space. The danger space. As previously mentioned, the retropharyngeal or the buccopharyngeal fascia and the alar fascia, they tend to fuse at a variable level which lies between the C6 and T4 vertebrae, and it forms the pouch at the inferior extent of the retropharyngeal space. However, if infection succeeded to pass through the alar fascia and it gets posteriorly into the danger space, and the posterior superior mediastinum will most likely become infected and involved. The inferior boundary of the danger space is the diaphragm, which puts the entire mediastinum at risk. So when you realize that you are in the danger space, in a space that might lead you inferiorly to the mediastinum or ends inferiorly by the diaphragm, you should better sober up, and you should better get ready and get alerted and alarmed. So anatomically, what are the boundaries of the danger space? It is bounded superiorly by the skull base and anteriorly by the alar fascia, while posteriorly it is bounded by the prevertebral fascia between it and the cervical vertebrae. The disaster comes with the inferior boundary, where it comes to an end at the level of the diaphragm. On the other hand, the retropharyngeal space is found anterior to the danger space, and it is bounded between the buccopharyngeal fascia and the alar fascia, which tend to fuse at a variable level which lies between the C6 and the T4 vertebrae. Usually there exists a midline raphe in this space, so some infections of this space appear unilateral. On the other hand, the danger space is the median space without a midline raphe, and hence the infection can spread easily from side to side or to either side. And so the danger space gets its common name from the risk that infection in this space can spread directly to the thorax and the mediastinum, and it is also referred to as the alar space. And as previously mentioned, it is bounded posteriorly by the prevertebral fascia, which is the intervening between the danger space and the prevertebral space. However, the prevertebral space is rarely involved in odontogenic infections because the prevertebral fascia usually fuses with the periosteum of the vertebral bodies. However, it can get involved usually with osteomyelitis of the vertebrae, and the danger space extends from the base of the skull to the diaphragm, and it is continuous to the posterior mediastinum, and here lies the problem. It can lead to mediastinitis. The mediastinum is the space between the two lungs, and it contains the heart, the phrenic and vagus nerves, the trachea and the main stem bronchi, the esophagus, and last but not the least, the aorta and inferior and superior vena cava. So giving infection a chance to reach the dangerous space can lead to mediastinitis, and the patient presenting with mediastinitis can have an overwhelming infection, which might compress the heart and lungs, interferes with the neurologic control of heart rate and respiration, furthermore ruptures into the lung, trachea, and esophagus, and even spreads into the abdominal cavity. Unfortunately, the mortality rate of mediastinitis is very high, even with the modern methods of care, such as open thoracic surgical drainage and close follow-up with serial computed tomographic scans and IV antibiotics. Albert Einstein once said, "Everyone is a genius, but if you judge a fish on its ability to climb a tree, it will live its whole life believing that it is stupid." And finally, I would like to thank you for your kind attention. Thank you so much.